They haven't, thank you, Maurice. They haven't so much as sent me a certificate.
Oh, okay.
They did send me a big fat check. So that was nice. But part of which, of course, I'm going to give to the union that organized the strike. But that's another matter for another day. So, what do you think, Dan? Shall we begin? Are we still waiting for you? Oh, got people in? Okay. So today's speaker, thank you. Welcome to the Care Forum. Yeah, Maurice just said, and I'll second it. It's really a wonderful thing to be able to join you all for this meeting. Today's paper giver is Monique Lanoix, who is an associate professor in the Faculty of Philosophy at St. Paul University in Ottawa, Canada. Monique has written extensively about care since the 2000s, really, in both English and French, and her work has appeared in edited collections and journals, Hypatia, the International Journal of Feminist Approaches to Bioethics, the International Journal of Care and Caring. She co-edited a volume on aging in an aging society in 2019. And among her recent publications, of which she's proud, she tells me, are Just Aging, the Prudential Lifespan Account in the Journal of Medicine, Healthcare, and Philosophy, and in the Routledge Handbook of Feminist Bioethics, Toward a New Model of Aging, Feminist and Critical Disability Contributions. Monique has received many research grants to study care workers and is currently focusing her efforts on care for aging people. For example, she's now the co-investigator of a very large Social Sciences and Humanities Research Council of Canada partnership grant called Imagining Care, Friendly Communities Within Communities, International Promising Practices. So Monique, of course, has spoken and published throughout Europe, including in Norway, Slovakia. She's written extensively on practices of care workers, and she's often cited for discussions of care work as embodied labor and for what she called assembly line care. She's recently written several essays about care and robotics. But her paper today doesn't take us there. It's about care labor between two worlds. Monique, why don't you present your paper, and then, as is our custom, we'll have an open discussion. Please.
Thank you very much, Joan. Very kind introduction. And certainly we can discuss some of my projects, actually, because I do have some results I could share. My paper that I'm presenting is a bit different than the draft you got. It's from my book, The Radical Potential of Care Labor, which is, unfortunately, still very much a work in progress. In the first section, I make the case that relational aspects of labor are present in historical writings, such as that of Locke. The second section is dedicated to the ways in which commodification erases the relational dimensions of the laboring process. And in the final section, I turn my attention to recent writings on labor, especially the ones of Christophe Dejour that I'll be talking about today. And my goal is to show in the book that care labor highlights the relational nature of work, which is essential to a transformative understanding of labor. And this emancipatory concept supports calls for shifting the understanding of the citizen from that as worker to worker carer. So thank you for being here. All right, so the paper. One consequence of living longer is the need for assistive services to accomplish the activities of self-care. So in Canada, the paid services that assist individuals in the performance of the activities of daily living or self-care are called ancillary healthcare services. So those services include help with housekeeping, cooking, or tasks of a more intimate nature, such as help with dressing or bathing. Although the assistance is directly related to the well-being of those who require care, they're not considered medically necessary. And this is important in the Canadian context because it means that those services are not part of the Canada Health Act. Consequently, their provision is not federally regulated, regulated, and the regulation as well as the access are under provincial authority. Significantly, actually, not being part of the Canada Health Act means that for-profit agencies can offer these services. Understandably, the provision of care services has changed drastically as they become paid activities. And the consequences of the commodification of care labor has been researched in sociology, anthropology, and to some extent in bioethics and philosophy. Research has demonstrated unequivocally how caregiving is racialized, gendered, and above all, precarious work. The pandemic has instilled a kind of gratitude in the hearts of many who have loved ones in institutional settings or who benefited from care assistance in the home. For example, François Legault, the premier of the province of Quebec, still called frontline workers guardian angels. Note that angels don't get paid, don't have bodies, don't suffer pain or die, and apparently are on call all the time. Lalonde and Dufour titled their paper, Personal Support Workers during the pandemic, and this is significant, From Zero to Hero. As they note, the hero or guardian angel narrative normalizes a situation that is not normal. However, as the pandemic appears to recede in the collective imagination, paid caregivers have become, once again, invisible, just like guardian angels. In this paper, I examine paid caregiving in institutional setting, that is, in nursing homes, as they more clearly illustrate the impact of regulatory frameworks. In keeping with the focus of my book, I make the case that caregiving labor reveals a forgotten facet of work, relationality. Now, relationality may appear to be an obvious facet of caregiving. However, the manner in which it is commodified effectively erases, or at the very least, becomes an article to the creation and maintenance of care labor's relational dimensions. These dimensions flow from the act of care. So in order to probe the specifics of paid caregiving, I use examples of workarounds to illustrate how the commodification of care leads to a suppression of the inherent relational dimensions of care labor. So in the first part of the paper, I explain the institutional context of paid caregiving, and I follow this with two examples of workarounds. Workarounds are the ways in which workers circumvent the rules and regulations of an institution. Following the two examples, I discuss the central concepts, or some of them, of the psychodynamics of work, which is introduced by Christophe Dejour, and I examine how those concepts play out in workarounds. Finally, it is my goal to draw together these seemingly disparate concepts in order to demonstrate that care labor, far from being a boring, repetitive, low-skilled activity, is one that is ethically complex and challenging. Ancillary care regulations and workarounds. So in the current residential nursing home context in Canada, and I would venture to say it's very similar in the US, the physical tasks of care are the ones that figure predominantly as they frame the scheduling of the activities. And they also serve as a kind of barometer to evaluate whether the care provided was more or less adequate. Paid caregivers are called here, especially in Ontario, personal support workers, or they are called orderlies or care aides in Quebec, préposés aux bénéficiaires. And the individuals are tasked with the activities relating to the physical needs of residents, such as dressing, toileting, feeding, and positioning in a bed or chair. The caregiving activities are usually described in the literature, and certainly in the media as well, as semi-skilled or low-skilled, or unskilled, actually. Personal support workers, however, provide 70 to 80% of the direct care to residents. Now, in nursing, it's largely agreed that emotional labor, that's Hochschild's term, or sentimental work, Strauss's term, is constitutive of good nursing practice. This is the type of labor that takes place while prioritizing a medical procedure. This would happen when a nurse reassures a child while administering a flu shot, for example. Emotional labor can be a comforting touch or a speech act aimed at some form of communication. Many nurse theorists have argued for the recognition of emotional labor. However, since it's hard to chart, it's usually not accounted for. In a survey of nurses in Canada and the UK, Anderson found that, quote, nurses as well as other caring practitioners certainly view emotional labor as an important facet of their work, end quote. But she acknowledges that it can come at a cost and needs to be supported with the safeguards that are put in place. If this is the case for nurses, it makes sense that it should also be the case for personal workers, since they are the ones who are most directly and more often in contact with residents. Personal support workers often want to have exchanges with the persons they're caring for. It humanizes the care. However, there's little time for this to take place. In highly regulated institutions, care labor is assigned to specific caregivers to be performed at specific times. In their comparative study of 3 regulatory contexts, Canada, Norway, and Germany, Daly and co-authors discuss how some regulatory contexts are prescriptive while others are interpretive. They explain, quote, prescriptive regulation identifies what should be done and which staff should do it, and delineates when and how they should do it. In contrast, interpretive regulation is more open-ended. It identifies that care should be provided, but not which staff should do it, nor when or how it should be done. Prescriptive regulations do not support the performance of emotional labor. If speech acts are uttered, they usually tend to be strategic. Prescriptive is what would describe the care context in Canada, Ontario, Quebec, and certainly I would say in the US, except in outlier types of nursing homes. Now, what does this imply for the resident? Well, this means that Ms. B might have to be coaxed to take a bath at a specific time, like your daughter would want you to be clean, kind of thing. However, she might have preferred taking her bath at another time in order to have a chat with perhaps a resident. In a prescriptive context, this is not possible or rarely accommodated, as it would perturb the entire scheduling of care activities. It really must follow a schedule. So the consequences of structuring care labor in this manner also has a negative impact on caregivers. If interpretive regulations allow for initiative, prescriptive regulations are more precise as to the purpose and the timing of care activities. And there's little room to invent or improvise. And despite or because of such regulations, personal support workers may find it difficult to reconcile the goal of good care within a prescriptive regulatory framework. Personal support workers are in a difficult situation in highly regulated regimes. Even if they have a sustained contact with the residents of an institution, caregivers do not have much input in the care plans developed by medical professionals, usually the head nurse in consultation perhaps with the attendant physician. In a study of care home workers, Defarge and co-authors concluded that actually care provision is driven by policy, not by what happens on the ground. So caregivers face 2 regulatory obstacles: how the work is structured and their powerlessness in effective change. Nevertheless, some workers manage to circumvent the rules in order to provide adequate care or to get around schedules. And this is done through workarounds. Writing from an American perspective, Nancy Berlinger of the Hastings explains in her book on workarounds, workarounds can help us understand the nature of contemporary healthcare work. So in the following, I discuss two examples of rule breaking or workarounds. So the first case takes place in Quebec in a nursing home, and there are strict rules for repositioning a resident in the bed, in his or her bed, or even in a chair, actually. Two people must do the repositioning together, and this is in order to prevent injuries to both resident and caregiver. In this particular afternoon, personal support worker enters the room of a resident in order to reposition him in bed. He does not want to wait for another worker, so he decides to do the task by himself. In repositioning the resident, he gives a big push. The resident ends up hitting the railing of the bed, but seems fine. So the personal worker just leaves the room, goes on to his next task. According to the rules, this is an accident and should be reported, even if no harm is apparent. When the family of the resident notices a bruise on the resident's throat, who happens to have dysphagia, which is not really, doesn't help the case here, they alert the head nurse. She calls in the worker and he explains what happened. His co-workers rally around their colleague, saying he's essentially a good guy. He wouldn't try to harm anybody by on purpose, for sure. So they chalk it up to poor scheduling or time pressure, one of those things. No further action is taken except to reiterate that repositioning should be performed by two workers. Now, the second case is a little bit different. Nursing homes have strict rules about sharp objects. Safety is a concern. Residents cannot always be under the watchful eye of a caregiver, so we can't let them have sharp things. However, this particular female resident is quite agitated, and she fiddles constantly with her hands. Personal support worker who's worked with her has noticed this, and she thinks the resident would not pick at her hands if her hands were kept busy. So she talks to the daughter of the resident, who mentions her mother's love of knitting. They agree that giving her mother a pair of knitting needles might be good, and so they decide to try it. The resident is now quite content to sit and knit. Quality of life has improved as her agitation is lessened and she's busy. Nevertheless, the personal support worker has broken the rules. It is her responsibility to give the knitting needles, and she could face negative consequences. So in the first case, the care worker is seeking to become more efficient, staying on schedule and getting the task done in order to get to his or other activities or his coffee break or whatever are most important. The resident was repositioned, so the goal of care was met. It wasn't met well, but it was met. In the case of knitting needles, the focus is on the resident. Personal support worker readily identifies the agitation as an issue that could be addressed with some reference to the resident's life. She could instead have told the nurse about the agitation, and the nurse might have asked for a consult with the attending physician, who could have then prescribed some kind of anti-anxiety medication. However, that's not what happens. Personal support worker endeavors to solve a problem by looking at the whole person. For that caregiver, the risk of the needles is less serious than agitation. Instead of thinking of the resident as someone who has physical needs right now, she perceives the resident as having a history in some agency, and also as being part of a network of families, right? And this makes her reach out to the daughter. In her discussion of workarounds, Berlinger writes that whether workarounds are ethical or not depends on the rule that is broken and the reason for breaking that rule. So it's not clear in the first case that the rule breaking was of benefit to the resident. In fact, the outcome leads to the opposite conclusion. In the second, we can say it's justifiable. So there's elements of these two scenarios that can benefit from de Joul's writing on labor. And I'm going to discuss that next. So Christophe de Joul is a psychologist. He has been writing since the 90s. He's now emeritus in France. I'm not sure which school. And what he calls his approach is the psychodynamics of work. So de Joul's reflections on work took place in the wake of workers' suicides in France in the early 2000s at France Télécom, which we did not really hear about in North America. And there were many suicides, actually, of workers, and there were structural changes at France Télécom, which has changed its names, actually. So this prompted de Joul to look at suffering in the context of work. So for de Joul, work is activity, inventiveness, and cooperation. To work consists in collaborating with colleagues, being part of a hierarchy in order to produce an object or provide a service. Work involves dealing with regulations, procedures, even tools. It's also about learning to function with colleagues and to get to know them and to interact with them in order to get the job done. If work can be fulfilling, de Joul understands that work can also generate suffering. One aspect that I find especially compelling in de Joul's writings is the recognition that the activities of work do not necessarily, and most often, do not evolve as predicted. De Joul names the unpredictability of he calls it the real of work. The real is what becomes known to the worker and pushes the worker to think and act differently from what had been planned. It is what de Joul calls a décalage, a gap. The adjustments a worker makes to bridge the gap between what is prescribed and their actual activity can never be fully anticipated. So the gap allows the worker to invent, to use their subjective knowledge, and to cooperate with others. And this is significant for the psychodynamics of work, because work is a social activity taking place in a social setting with others. It is also social in a broader way because the recognition of work takes place in a social or an environment or a society. Or work is a living activity, what he calls a travail vivant, where the work and an object of work or service are not separate. The negotiation that has to take place in order to manage the real of work necessitates having to relate to the object or task of work. This perspective on the activities of work and the relationship of worker product of work are quite different from the ones implicit in Fordist or Taylorist models of work. So I believe that work's conceptualization of work is well suited to examine paid care labor, as human beings are quite unpredictable. De Joul, in addition, posits that everyone negotiates two types of world, that of their families, the proximal world, and that of the public sphere, or the sphere of so the social world, the distal world. And he discusses this in his 1998 book, France en France, which has been translated in English, actually. Now, the notion of distal and proximal worlds is of use in trying to understand the cases of workarounds I described. When applied to institutional caregiving, personal support workers are in a different environment than most workers. They are taking care of frail individuals. In nursing homes, usually older adults. Generally, in a sort of broad way, all service workers operate in a proximal sense, right? The server brings you your food, the massage therapist touches your body, the nurse can ask questions of private nature. However, these workers have a set of rules of conduct that helps them set boundaries. Personal support workers do not benefit from professional distancing to quite the same extent. So first, in assisting someone with the activities of daily life, which are often intimate, the care worker is always in close contact with the person she's assisting. And there's a lot of touching and so on, right? The everydayness of care tasks makes them kind of familial by nature, and the contact is often close and sustained. For example, the same personal worker may assist the same resident over a period of days. And this is what everybody kind of wants because they get to know each other. Personal support workers are laboring in a home-like environment, which is what a nursing home is supposed to be. And personal support workers often identify being a good worker with some form of engagement. But personal support workers are not regulated, as they are not part of a profession, and the directives given by administrators, such as don't get involved, are of little practical use. There are codes of conduct that will formalize the encounters between the workers and the person requiring assistance, but as we saw in the workarounds, there's usually regulations, right? Concerning sharp objects or the safe performance of physical tasks. On the other hand, if we think about the work, ancillary care is a paid activity, a type of employment. It belongs to the distal world. The personal support worker is in proximal relation to the resident, yet that resident is not part of that caregiver's family or close others. The person being assisted is of the distal world, the world of them, not us. This puts caregiving in two types of worlds, and caregivers must negotiate these two worlds as best they can, and often on their own because the regulations are of little use. In an article on violence in care homes, Isabelle Gernet and Florence Chekrum use the psychodynamics approach to examine how a violent act took place in a nursing home and what that violent act was intended to resolve. And here they move away from the bad apple kind of way of dealing with abuse. The violent act was a slap on the face of a resident who wasn't cooperating, and it came from a care worker who had been praised for conscientious work. The authors conclude that the slap was in part a consequence of certain organizational deficits. These were a lack of space for deliberation between the workers themselves in order to self-regulate behavior, the impossibility of raising problems in meetings, and the increase in workload. Now, using what they did in that case, I'm going to examine what happened in the case of the first workaround. So staying on schedule is what he identifies as most important. Subsequently, he's not given the opportunity to reflect on his behavior. He was simply told to follow the rules next time. He was also working alone, and this is very typical in nursing homes, actually, and increasingly as care measures have been put in place. And Gernet and Chekrum, one of the possible pitfalls of working by oneself in such situations. They point to the beneficial effects of discussing care tactics with coworkers. However, when informed about the incidents, the coworkers did not reflect critically on the problem of scheduling to any great length. Rather, they displayed defensive behavior. This type of behavior takes place when the real of work is confronted and no resolution appears to be available to the workers. There's also resistance on the part of the workers as the complaint was raised by a family member. The resistance reveals how the resident and family are in the distal world, the real world of them, not us. So there's little room for inventiveness or cooperation in this first case. As is typical on nursing home units, the meeting at the start of the day is to assign care activities. Personal support workers are told which residents will be under the care and which activities must take place. For example, bath time, 2 o'clock. In this highly structured context, which relies on prescriptive regulation, there's little opportunity to build teamwork, which is another important facet. Communication between personal workers and a resident, as well as communication between the co-workers themselves, cannot take place in any meaningful sense. And this has also been corroborated by work done by François Aubry, who's actually looked at care homes in Quebec. In the second scenario, the caregiver acts beyond what she's expected. She's responsible for physical care, yet she notices agitation. Whether the resident is fidgeting or not is not under her purview, since that resident is really not harming herself or anyone else. But the caregiver addresses the fidgeting in order to make the resident as comfortable as possible, because she sees this as flowing from her job. She uses her inventiveness, her judgment, and arrives at the solution by speaking to the daughter. The residents perceive as a whole person with needs that transcend physical needs, and also as being part of a family. The knitting needles are a tangible expression of her past and current interests. So what the worker does is negotiates the proximal and distal worlds effectively by speaking to the daughter, recognizing the kind of, reaching out to the proximal world of the resident as a way of addressing the resident's history and performing her job. Now, one of the problems, I guess I'm running out of time, but it's almost, one of the problems facing institutional caregiving is that it attempts to import the labor of care into the world of work, of commodity production. And as I mentioned at the start, there's been numerous critiques. However, I want to look at the issue from another point of view. And one that I found quite interesting is the chapter by Gooding and Gibson, The Decasualization of Elder Care, which focuses on caregiving for older adults in the community. And they discuss how care activities used to take place in the home and the ways in which the nature of caregiving has changed when the care is becomes more medicalized, actually. So what they write is caregiving of the traditional sort was casual in the sense of being ancillary to something else in the relationship and the activities emanating from it. So put differently, the care needed either by older persons or children was integrated into the activities, onto the other activities of daily life. So asking about somebody's day while cooking supper and so on. But with the increasing complexity of care as it seeks to address medical and physical needs, and this is especially the case in the care of older adults, it has to take place outside the traditional setting where care was casual. The activities of care become decasualized as they take place for their own sake. They no longer flow from relationships. So Gooding and Gibson's discussions highlights how the requirements of complex care are difficult to address and can easily become primarily medicalized. This reveals how community care provision attempts to emulate home care without addressing the impact of the transformation of care needs. In a parallel way, institutional care parachutes care services in a highly prescriptive and medicalized environment. Now, one thing that Gooding and Gibson explain, which I find really quite instructive, is that casual care is characterized by the absence of why should I. If it happens in a familial setting, we don't ask why should I. It could, they say, happen in an institutional care, although I would say it's pretty hard. But I think it's really interesting. In the first scenario, the personal support worker did not entertain the possibility of waiting. Why should he have to wait? His job requires repositioning a body. Clearly, the resident is part of the distal world, the world of them. He's kind of something to be done. This care is decasualized as the activities are disconnected from any other activity or relationship. There is little time or space to relate to the resident or even perform some speech acts that would be part of emotional labor. And it might have been a case that the resident was sleeping, right? Now, connection is evident in the second scenario. Not only is the personal worker able to perceive the resident as a whole person, she takes the initiative of talking to the daughter when she sees her in their nursing home. So she basically engages with the daughter and they come to an understanding that the knitting needles may solve the problem. So the caregiver has managed to navigate the distal world of her work to that of the proximal world, the resident. This caregiver is driven by the why shouldn't I? And it flows from her relationship of care that she has with the resident. Now, I'm not saying that the personal support worker should perceive herself as a part of the family. Rather, the casualness of care in the second case flows from the relationship that is inherent in the care provision. In addition, also, I really want to stress that it's not a supererogatory act. An example of that would be a care worker who stays a bit longer than her shift in order to keep company to a resident because no one else will, or goes shopping and buys something for the resident outside of work. It is a matter of I really should because no one else will. There is a sense of obligation which supersedes structures of care. In the case of the knitting needles, the inquiry to the daughter flows from the relationship the caregiver has with the residents. So in sum, we have the why should I, why don't I, and I really should illustrate the ways in which care workers negotiate care within regulatory regimes. So to conclude, Dojo acknowledges the connection between the worker and the task to be accomplished, the service to be provided, or the final product. And the relationship is one that is instrumental. The workers must navigate the unforeseen and manage their activities accordingly. If this acknowledgement is a step forward in understanding work as a relational activity, I don't think it goes far enough. Dojo states that work is a social endeavor. However, I prefer to say, and I need to work this out, but anyway, that is more deeply social. Work is relational through the acts of labor, care labor, and actually work is relational, I guess, in the Dojo sense, but care labor clearly illustrates that it also has the power to move workers. Now, Dojo understands that work can produce suffering, so he does sort of understand how there's that connection, but he doesn't go any further, which I think I need to explore. And in the draft of the paper, I talk about the logic of the gift, which I can't address, obviously, right now. So how can care giving response to the specificities of care labor? Well, one, interpretive regulations should be put in. I haven't discussed this in this paper, I've talked about it elsewhere, is that prescriptive regulation clearly illustrate how personal support workers are not taken to have epistemic authority. It is an example of testimonial injustice. Furthermore, the reluctance to support teamwork also speaks to this way of perpetuating the understanding of care work as low-skilled. So workers are put in a different bind. We can't trust workers to do whatever needs to be done. At the same time, they are taken to be the ones that are there doing the work all the time. And so I think it leaves care labor is a rich endeavor that needs further exploration. And as a last point, I should say, why do I know so much about this? So I've never been paid to perform care activities. And I have been in nursing home environments for many years, where I had the opportunity to witness good and bad care. And as an example, the personal worker that I was talking to, who had 10 residents to take care of during COVID, and the only one that survives was my husband, Mike. And just the way she put her hand on his shoulder and looked at him and was telling me this was really a gift in many ways. And also, the personal worker who came into Mike's room, put her hand on his arm and said, "You have courage. God loves you." He stated many times that the good life is reached when one lives well with and for others in just institutions. These women showed that they could live well with and for others in spite of unjust institutions. Thank you for listening.
Well, Monique, thank you for this paper and for the deeply moving ending. So are there questions or comments that people would like to make? I guess we could either, you could just raise your hand or use the chat, the little reactions hand up button, because then it'll come up. But I see Eva has her hand up, so why don't we start with you? Thanks. Eva, I think you're muted, so.
Monique, this is a wonderful, wonderful paper, so rich and may I say so useful. I am thinking of taking this and bringing it to the head of the place where my daughter lives. And I have, since my daughter is in a so-called institutional setting, though I don't think of it as institutional. I've seen exactly these dynamics at work, and to have a way of characterizing them and talking about them is enormously helpful. I do have one question, and that is about scheduling and regularity of scheduling, because I think that at least in some sort of situations, maintaining schedule is really important, not so much for the staff, but for the residents, where they really require, where they thrive when they have that kind of regularity. So that's one thing that sort of pushes against some of what you say, certainly not all of what you say. And I'm wondering if you've thought of that. And secondly, could you please put the reference in the chat box to du jour?
Oh, yes. You're right, actually. And certainly my husband had a traumatic brain injury. And so for someone with a traumatic brain injury, it's really important to have a framework. And you're right, some scheduling needs to be done. And I should add that some institutions are able to accommodate to a certain extent, although it's really difficult. So I would say in the best case scenario is that you personalize the care plan for the individual. And what I think that's really important in personalizing the care plan is to ask the caregivers, the ones who are on the ground, to have an input and to say, well, what do you think? Do they like having a bath on Tuesdays or whatever, so that things can actually move and provide good care. And it's amazing how little communication takes place, even during the pandemic. Because I had a project interviewing personal support workers during the pandemic, and there seems to be a disconnect, and I'm not exactly sure. Administration says, yeah, but we tried really hard to tell them, and the caregivers go, well, we don't know what's going on. So what is what is actually happening? But yeah, you're correct. I mean, scheduling can be very useful for the resident, and not just because it saves money, basically.
Thank you, Eva. Thank you, Monique. Dan Engster.
Yes, thank you. Thank you, Monique. This is a great paper. This is really interesting, and I have lots of thoughts running through my head. And so my question is really asking you to kind of connect up a couple of the strands of your argument, so I can understand them a little better. So by my understanding, or one way, at least what I was hearing and kind of focusing on in my own mind, is that maybe one of the major problems here are this high regulation form of organization that you find in nursing homes, and you also find, right, more or less since Max Weber and this kind of model of bureaucracy became popular, in all organizations, and I think some of the dysfunction you're describing in the nursing home from these high regulation model of organization also you can find out kind of throughout the administrative state for all people who are doing service work. So I find that really interesting. But then you also a lot of your talk talked about this contrast between care labor and commodification, and so I guess in my mind I'm understanding your discussion of care labor as sort of striving to articulate what the parameters of ethical action are then once you give, say, workers in nursing homes the discretion to actually perform their job according to what the purposes of it are, or I guess I'm trying to kind of understand the connection between the high regulation organization and then the discussion of commodification and care labor and how all that fits together.
Okay. Well, care labor, in the way I understand how it's performed in your traditional, if you want, and actually tends to be performed in this way, especially in for-profit nursing homes, is that it is really assembly line work. Nurses are, so RNs are not involved in any of the sort of physical care, but they come and this was amazing when I saw it, they come and check for bruises and so on, right? So they sort of have this view of, okay, I'm checking the resident. So it is very, sort of legalistic in a way. We don't want to be sued. So we don't want any bruises to be, we want. So it's very regulated in that sense. You have to feed the person at noon. I've seen caregivers who have 3 individuals, and this isn't a for-profit, and they're feeding one, they're feeding the other, they're feeding the other, right? So that's kind of, and the product then is you look at the food tray and you go, okay, he ate, half of his meal, he consumed all his liquids, good job. The other regulation, which is in Ontario, is actually you can't leave the food out for more than so many, minutes or hours or whatever, right?
Mm.
And of course you understand, and you don't want something to be there for a whole day. But it's very like, what if the resident doesn't want to eat? What happens to the food? And sometimes the food just goes back to the kitchen untouched. So that's what I mean. It's a commodity, is that you have these, okay, this much food was consumed, this was done, this was done. Repositioning is another one, because of pressure sores, you have to reposition between 2 and 4 hours. So you go, okay. So this is what I mean by commodification. The care is a physical task that was done or not done, and we're happy or we're not happy. It's kind of like, did you take your medication, and so on and so forth. So that's what I'm getting at. Now, so regulations make that, prescriptive environments possible, right? Everything flows. In interpretive regulations, and that was seen in Europe, actually, it's like, well, we got to make sure that, you certainly need to make sure that people eat. And it won't necessarily be assigned so rigidly, but the nurse will oversee and can ask the workers and so on. And so this is what I mean by interpretive regulations. Then make it more of a, well, they do make it more of a home-like environment, is that, okay, I feel like eating at 3 o'clock. Okay, we'll put your food away in the fridge, because usually a fridge will take it out again, and then, we'll give it to you. This, I've seen it done in a regulatory, very prescriptive context, but it's always like a burden on the caregiver or the personal support worker to all just go put it, and I'll come back and give it to you. It really asks them to make an extra effort, right? So that's really what I'm trying to get at. So interpretive regulations kind of encourage the care relation to be, I guess, well, encourage a kind of care relation, and from that flows the taking care of. So you kind of care about to a certain extent, and from that you can actually provide the care. So I don't know if that helps.
Dan, does it help?
Yeah, it does help. I just very, very briefly. So I guess it still seems like the major thing is the regulatory framework, right? Because I guess I'm sort of still getting caught up a little bit on the commodification part of it, but whether it's for profit or not for profit, you can have these 2 different kinds of organizational frameworks, which really will matter, or whether you're in a capitalist country or not, right? Europe has these, in general, has these, this much more kind of flexible bureaucracy that gives much more discretion to, lower level administrators than a country like the United States. And so I don't know, I guess I sort of just see these as 2 models, 2 organizational models. And the United States is very much hung up on this like Weberian compliance model. And I think mostly just because we don't trust street level workers to make smart decisions, and I don't know, we trust doctors and lawyers, but we don't trust the social workers to be professionals. And so that's kind of the origins of my question. And
yeah, I would say we see that or it's easier to get the commodification when you look at home care. So somebody is paid to go and give a bath. She's got 2 hours to do it. She's, if it takes her an hour to whatever, and that's I was in a care home in Germany, which was pretty amazing actually, because they had they had I guess a kind of program to hire younger individuals to just come and sit with residents and just to be there, like it was like social care. And so they were there and they were hanging out, and it was really kind of neat to just see that being integrated. And then, you know, they would cook potatoes, like there was a kitchen, and it was were all around with the kitchen, and there was cooking happening, and some families or residents would help with the cooking, and then a woman would come from another unit and say, I heard you had potatoes, and so she would just come in and eat the potatoes. Potatoes are a big deal, and so it was really neat. And there is another case also of a resident who was in a wheelchair and not verbal, with one of the apprentice, this is what they were calling them, who gave the woman a potato and a potato peeler. So all of us from Ontario had like big eyes, like this is like a sharp object. Oh my God, there's going to be blood everywhere. But no, it was really touching to see this woman peel the potato, and she was so concentrated. And it was, you know, it was like, yeah, this is nice. So this is uncommodified care.
Great. Thank you very much. Amy Mullen, please.
Hi, Monique. Thank you so much, as always. I always admire your work. I wanted to kind of follow up on what Dan was talking about in terms of and your response in terms of the interpretive framework for thinking about care. But I wanted to ask you whether you think that opens up the possibility for personal support workers and frontline workers to be included in the community of interpreting whether or not the care has been met. And because that seems like it's not just that we need the kind of like the interpretive approach to care, but that we also need to be listening to the kind of the knowledge of the personal support workers and trusting them more.
Yeah, no, that's an excellent point, actually, because there's rarely, you know, when something goes wrong, then there's a meeting about what went wrong. But there's no meeting at the end of the day, right, to say, how was it? The other thing, too, is that some care workers might have a real problem with some residents. And there's no real way to address that and say, what is going on, and how can we, you know, either change the order or whatever. So yeah, there's never, so there's the meeting at the beginning of the day, you do room 1, 2, 3, and that's it. So yes, I think there is definitely a way to kind of integrate everybody's. In the study I was mentioning that we did on care workers in a nonprofit home in Ottawa during COVID, actually there was most of the results were predictable. There was a lot of issues about the changing regulations and so on, and but there's one unit or one or two where there was actually cooperation amongst all levels, from the nurse to the LPN to the care workers, because one care worker had a hard time with a mask. So everybody came in and kind of worked together to get her to fit the mask or whatever. So there was through cooperation there. And it's really interesting that it happened on this one unit. I kind of wonder why, but yeah, it's so it can happen, but yeah, it doesn't.
Thanks.
Thank you. Our next questioner is Tatiana Talin. You're joining us from Vienna?
Yes, and no, actually from Berlin.
Oh, okay.
Yeah, thank you very much. A very interesting paper, and it's such a hard task to kind of trying to systematize what seems intuitively good care or not so good care, and I think it's very complicated. So I thought this was very interesting, but I have some questions. So basically the first one, like the good example, and I think everybody wants to be seen as a full person and this special needs and interests and so forth being acknowledged. But of course, what would have happened if the other day everything would have been full of blood, right? I mean, what would have happened if the needle would have gone right into the eye or something else? And then, yeah, so this is well, this is more like the empirical question. And the other one I thought was very interesting, the de jure distance and proximate worlds. But I wondered if not kind of through the back door, there comes the family state or family bureaucracy kind of division back in a way like naturalizing the family care by naming it differently. So it doesn't have to be a relative. Social proximity could be also somebody else, but then in the end it was all about family. And also the gifting of care is seen as in the family, and this kind of seems to me like going back to what feminist and disability studies have criticized, because there is all this bad care, and the way you also described it, the shift from traditional, talking while cooking and so forth, kind of doesn't takes into account how many elderly people were just locked up in family homes without talking to them or without, even doing the physical care. So this would be my kind of second question. And a third question is, because you said this like so often, like the care flows from the relation. And I think it could be also the other way around, that the relation is established through care, which then I would come back to the second division again between the distant and the proximate world. Isn't that, at least in some cases, what seems to be the distant world can become the proximate world, meaning the institutional environment? Let's say in the good case, let's say it's an ideal institution where good care is performed, and then relations come, and this becomes there is also kind of a blurred boundary or a transition from one world becoming the other. Or is it? That would be basically a question. Thank you.
All right, thank you. Actually, Berlin is one of my favorite cities. That's an aside. To start with the first question about the knitting needles, yes, I don't have the outcome of that particular workaround. I suspect, however, that there could be a way around it, in that knitting needles can come in many shapes, and there's possibilities of having rounded ones. And also the possibility of putting the resident in front of the nursing station so somebody can have an eye on her. But yeah, you're right. There are, and the question of risk is a big one. And nursing homes are risk averse. We can understand that, but what does it mean? If you guarantee no risk at all, what kind of environment do you have, right? And so I think that's the issue. And the potato peeler actually case or example was that this particular nursing home was certainly allowing a lot of risks to take place. In fact, some of the physicians on this project were horrified because somebody had dropped a pill somewhere, and then somebody just swept it up. It was like, this is just this doesn't happen. It's not supposed to happen in care homes in North America. So there is a certain amount of liberty with risk. And so what is, and you know, people do actually, administrators in long-term care do think about it, like what risk, what level of risk is acceptable, of not allowing somebody to walk around because they might fall. What kind of life is it if you're stuck in your room? So this is, again, yeah, so it's something that needs to be managed. Now, the case of abuse, it's true. Idealizing familial care is problematic. Obviously, some older persons are, you know, stuck in a home away from, you know, the sort of, it's assumed that because they're home, they're well taken care of. That is not the case. However, the point of using casualness of care is just to kind of illustrate how care takes place while other things can take place. And interestingly enough, there's a study in Finnish care homes where care workers were asked, what would you want a robot to do? Would you want a robot to actually perform intimate care? And the workers said no. And I suspect it's because when you perform intimate care, you talk to the person, you relate to them. And that's the idea here of the sort of physical tasks of care are not dissociated from the relationship, the talking, or maybe just, you know, the holding that can take place during the care activity. So it is in that sense that the casualness, I think, is of interest, because it just kind of shows that you don't have to compartmentalize all these different activities into discrete, you know, okay, reposition. And I mean, that's, you know, it's vital in a nursing home to reposition individuals because they can get pressure sores and that. But, you know, to just come in and move somebody like a sack of potatoes, that's a bit of a problem. And it doesn't really encourage the workers to build some kind of relationship with the person they're caring for. And now, yeah, and I think you noted, I said the care flows from the relationship, but certainly the way people are viewed will influence the care they receive. So if someone living with dementia, for example, it's like, oh yeah, that person's lost. And the residents committee that I examined, or I was part of, actually, was the person leading the residents committee was very she advocated, because she said, you know, the care work, they assume because somebody has dementia that you can send a care worker in to take care of them because they won't realize what's going on, and so on. So we see here that how the person is viewed, or the relationship we may have with that individual, in the sense of, oh, they're a lesser individual because they have dementia, then, you know, anybody can go and give care. And the point here was actually the residents were advocating for having gender appropriate caregivers. So if a woman wanted a female caregiver, she could, and so on and so forth. So I don't know if that addresses some of the issues, but those are really good points. Thank you.
Thank you, Tatiana. Thank you, Monique. The next question comes from Iris Parra.
Thanks. And thank you, Monique, for your talk. I guess my experience is quite different because I come from Spain. I worked I've worked as a nurse both in hospitals and nursing homes. So, and what I'm going to share just a few things. So maybe it can help think about some of the topics you talk. It's not exactly questions, but then it guides me to questions. So the first thing is that I have the feeling that it's when you try to create these categories about interpretative or normative frameworks, for me, it doesn't really make sense because I always have seen them together. So it's a mix of both of them at the same time. So, for example, when you say that cooperation is weird, I've never been in the context in the States or Canada, right? But for me, the usual thing was that I was a nurse. There was like what we call nurse assistants also, and we would both shower the person each morning. It was not that one had one task and the other. It was just that these things need to be done, and if we don't collaborate, this is not going to be done before the next task. So we work a lot together. It's difficult for me to see these differentiations in very, very separate spaces. The other thing that I think of is I think that we work in a more interpretative framework than the ones you were talking about. I think it also has to do a lot with whether the working team is a small team or a big team. If you have a big team working with a number of patients, it's much more difficult, the communication between them. And my experience tells me that one of the most difficult things while having an interpretative framework is not having an arrangement with the patient, because that can be adaptive, but how to communicate with the rest of the team so that you are changing the schedules and that doesn't create problems to other people and their own arrangements. So that's the most difficult part of that for me. So I would say that going for an interpretative framework would need or would also arise more conflicts between professionals working on that field. That's what my experience tells me. Also, it's much more positive for residents or patients or whatever the case. And I was thinking all the time about this mixed feelings, for example. We were talking about the idea of risk, and my experience says that nursing homes are not risk-free, never. It can happen one thing or the other. You can try to control things, but there's going to be always something going on. Someone can just disoriented and pee in a place which we're not for peeing, and another one can go back and flip on the floor. That happened once in my place. So, and I think that the risk in those cases were decided facing how many suits would families go against us. So that was the director would say, okay, so what's the most, what would be the worst thing that we could do so families could sue us? So they were thinking all the time about the family reaction to our actions. So that would be the amount of risk they were able to get. So I just gonna say, like, all in all, just to make everything, I don't see these differences that much. I always think that there's a mix of things. And in the nursing home, there would be patients working with the workers if they were able enough. So we had some patients that would sweep the floor, for example. They help putting on the table. So if they can, they do that. But of course, there's others that don't can. So of course, there's someone who is a worker, but at the same time, residents are carers one another sometimes if they can. So I don't see that their categories are much more like merged or swirled. So I understand that we need them to try to think of things, but my experience is that it's all too messy to try to put them in most places. I don't know if that makes sense, but I think that that's what I wanted to share, like my experiences in both these places. And just the last thing, when we were in a hospital, we tend to think, or at least many people tend to think about hospitals as a very separated, disconnected work between people. But I used to work in a hospital in which we were working with neural rehabilitation. So one of the things that we would do is work with the family or the caregivers at home, which wouldn't be necessarily the family, to help them and the patient to do the basic activities once at home. So we would do like when they were still at the hospital for 1 month or 2 weeks or the time that they needed to, just like train all of us one another, because sometimes they have techniques that we didn't know, and that also helps professionals then to improve. So it was like a shared space to put knowledge on how to develop afterwards when they go back home. So again, it's not just one place or the other. You have this function and I have another one. So it's more like a shared space. Yeah, that's it. I'm sorry. It took me too long.
Yeah, no, thank you for that. Actually, what you described is a little bit what was happening in that German home. And actually, because they had different levels of care. And so there were individuals who were there as like independent living, and there were a little bit more. And so for example, a resident from one unit would come and help make sandwiches for the residents in that unit. And that was really encouraged, right? They're really quite open about that. So it was really, like you say, a shared space. And because they had this communal kitchen on every unit, that was quite easily accessible because it was part of the system. It was easy for residents to move from ones that from different levels, and and come and so there was more of I don't know if it was family as such, but it was certainly not hospital-like, right? So it was a lot better. And involving the residents who could, make sandwiches or whatever, was a way of getting them to participate and to feel useful, which is an issue for many residents. And the fact that it was actually a circle meant that they didn't lock the doors, and they did not have individuals who tried to escape, which is what happens in different nursing homes. So so thanks. We need to talk more about that.
Thank you. Maurice, you have a question.
Yes, it's actually two little questions. I don't think it'll take too much time so we can get to Asha's question, but again, I really appreciate this this paper. I can't wait for the book to come out. I look forward to that. You mentioned, the lack of epistemic authority and autonomy given to care workers in institutions. And I remember coming across a study that said that for some care workers, it was when they transgressed the institution and took actions that weren't technically they weren't supposed to be doing, that they often found the most satisfaction out of that care work, that's when they felt like they were the most caring, when they kind of took that risk. And so it seems to me that there are ways that care workers can kind of exert their autonomy, enact their autonomy at times, although as you mentioned your example, sometimes that can go poorly. And the other, slightly related question is, you mentioned de Jules', commentary that care work can be fulfilling, and yet there's suffering that goes along with it. And we know the level of burnout and so forth that comes with it. You mentioned the one example of somebody who stayed later, but of course they stay later. They could be eating into their own care time, and do you also in your project, do you look at care labor holistically? We had a great presentation in this series on part-time for all, on how we need to reduce the amount of hours, and care labor tends to sometimes be very time intensive, and I'm wondering if it can be actually improved by creating less burnout, taking up less time in the workplace. So 2 questions. Thank you.
Yeah, yes, Jennifer Nadelsky's book, Part-Time for All, and the idea of reducing the actual work in order to understand how care needs to take place. That certainly would help. And yeah, caregiver burnout, there's many facets to that. One is it's recognized that retention is a problem for care workers. They enter the profession and they end up leaving because they just, well, actually, there's a prime example during COVID. It was pretty bad. In Quebec had one of the worst outcomes. Well, in Canada, actually, Ontario wasn't far behind in terms of deaths of residents, like 30 to 40% in certain nursing homes, as well as personal support workers. And so Legault tried to recruit workers by saying, you'll be paid for a whole year to train and to work. And then you have to work in a nursing home for, a year, and then you're scot-free. You don't have to reimburse the money. So workers were waiting until the 366th day to quit, because they said, we volunteered to provide care. This is crazy. I can't provide the care. It's just too stressful. So, and when the army was called in Montreal to provide care, one of the soldiers, and he was fairly highly ranked, he said publicly, this is really hard work. So this is a guy who's trained to go to war, and he finds giving care the way it's structured difficult. So obviously there's something wrong here, and somehow it's not being addressed. So that's certainly one point. Now, your first question, I'm not sure I got it.
It was more like an observation that I saw one study where care workers actually found it most fulfilling, their most caring when they transgressed some of the institutional rules to spend a little more time, or maybe hold hands with somebody when maybe technically they weren't supposed to be doing as much of that kind of thing.
Right. Yeah, no, that's right. And that happens in terms of home care also, where, the care worker will stay to have tea with the person who's at home because they're lonely and they feel bad, but they're not supposed to do that. Yeah, it's not part of their job. So it's true. Yeah, so they do want to have a kind of relationship, not for a human being. So they, there is not all residents are easy. They're as a challenge, I like this person because they're ornery, and I just like to be able to make them laugh, so there is that aspect, but it's hard to integrate within the system.
Thank you. This is the hard part of being moderator. We are almost out of time. It's 2:25. So Asha, we're going to let you ask your question. There is a comment in the chat that you all might want to look at. And then we may be out of time by the time we hear Asha's question and Monique's answer. But otherwise, Eva would like to make one last comment. Okay.
Okay, thank you for this very rich paper and for your work. So my question's also about the casual nature of care in the home, and it's sort of along the same lines as Tatiana's question, but it goes in a different direction. So I wonder if you've thought about the ways in which good care is provided in the home through power relations and through, broader social norms. Of course, patriarchy, plays a role, but in extended family systems, there are also complex cultural norms at play that ensure good care, in order to look at, what can be gleaned from the casual nature of care in the home, both the good and the bad, right? As we seek to inform these not public institutions, but as we seek to inform institutional care. So, similarly with Tatiana, I have a concern that there's a kind of idealization of the care that's provided in the home, and a sort of sanguine picture about the way that it occurs, when in fact, the way that good care is provided is going to be sort of regulated and implemented in part through relations of power and through cultural understandings about who should care for, for whom.
No, that's right. That's absolutely true. And in another, it's a chapter actually in a book on the Francophone contributions to care. I call it, sort of bare life, the Agamben kind of, so it's outside. And of course, care is provided within, you're right, patriarchal system by, sort of forcing or encouraging, or if the individuals are privileged enough to be able to choose that space and not be stressed or anything, and to have the space to provide that care. So it is certainly I would say integrated or impacted by power relations, both good and bad, right? And certainly in the nursing home context, or in the home care context, it becomes even more obvious. There are power relations where the caregiver is entering somebody's home, that person is paying for them, right? So there's an obvious power dynamic here that can act as a dominating factor to the caregiver. And so, one has to be careful when we talk about the casualization of care and so on, to understand that it is a political and framework that has set hierarchies that should be at least highlighted, if not questioned. So that's only a partial answer, but
I know we don't have time to talk about it further, but yeah,
it's a good question.
Thank you. Eva, we have time for you to ask a 30-second question.
My 30-second question is, to what extent are you talking about the question of training caregivers? Because we consider it as not skilled, semi-skilled, which we all know is wrong. But the training is also critical, it seems to me, for any kind of caregiving, whether it be in the home or whether it be in an institutional setting. And the other question I had was, there's sometimes a tension between the needs of the agency in terms of the caregiving for the whole group and the development of the staff, and the kinds of relationships that are actually formed. In my own daughter's place, we were just very upset because a nurse who's been there forever is so wonderful and knows the kids, but she was moved out of there because it was felt that she needed a broader range of experience and part of her personal engagement, which breaks up that relationship. And I don't know whether that happens in nursing homes or not, but those were the two issues I was wondering about.
Yes, well, the training is a good issue. I didn't talk about it now, but it's a bit of a scandal these days because there's so few caregivers that they're accepting caregivers that have been trained in by whatever private companies that are not recognized by the government. So they're just taking anybody. And the other thing that happens as well is that the training involves how to lift, basically the physical needs. Nova Scotia had, I don't know, a college degree, actually. I don't know if they still have it. For example, mouth care. Actually a caregiver was explaining how she would get her husband to open his mouth. She got him to sing, and when his mouth was open, she'd shove the toothbrush in his mouth and brush quickly and take it out again. So I mean, these are things that could be shared and so on. But yeah, the training is sadly lacking, and if people were trained better and had some explanations of dementia and so on, they might last longer, or they might decide, well, this is what I want to do, or this is not what I want to do. So that's, yeah. In terms of moving nurses or PSWs around, that has not happened as much. What I've noticed over the years is the attrition of the staff, of course, there are less people on the unit. Yeah.
Okay.
Well, sadly, we've reached the end of our time, so we're going to have to thank Monique one last time, and thank you all, and see you again soon.
Thank you so much.
Hello. Yes. Yes.
Thanks, Joan.
I'm sorry.
Thank you, Dan. Good to see you. Bye.
I'm just to turn something off. One second.